an honor to do that. Dr. Jones comes to us from the Linfield Good Samaritan College of Nursing, School of Nursing, where she is dean and professor. She has a long career where she's also on faculty and has worked for many years at OHSU as a professor of nursing and medicine there, if I've got that correctly. She has a wide range of interests. She's accomplished as a clinician and as a clinical researcher and as an administrator in medical education. Some samples from her thick resume include being director of the Family Nurse Practitioner Program at OHSU for many years. To give you a sense of her interests and expertise, she was recently invited as a speaker, a member of the Pain Management Best Practices Federal Interagency Task Force of the Department of Health and Human Services. She was invited as a technical expert for the Agency of Healthcare Research and Quality on the subject of non-pharmacologic treatment of chronic pain. She has a master's in nursing from Emory, a Ph.D. in nursing from OHSU, where she also did postdoctoral training in neuroendocrinology. She has had a wide range of interests, including persistent and chronic pain, dyspareunia, health needs of migrant and seasonal farm workers, the use of cannabis, yoga, and mindfulness in pain, just among some of these issues. In looking through her resume, it's very clear from extensive publications that she is, and I hate to set you up this way, but clearly responsible for a substantial chunk of what we know about fibromyalgia, and so it is a real pleasure to hear from our expert today. Oh, I forgot to say, next week I'm supposed to tell you that we're going to hear on our Victor and Betty Rosenfeld Memorial Lecture the insulin racket. Why is a century-old drug so expensive, and what can we do about it? My doctor is Dr. Jones.
All right, I'm going to see if I can be out here and not behind the podium so I can see you guys better. So let me know if you can't hear or if I get in the way of the text, okay? So we're going to talk a little bit about what's sort of the rational treatment of this fibromyalgia diagnosis that we all love. I do have some funding from the National Institutes and the Department of Defense and Greenwich Biosciences. Do you guys know who that is? They make plant-derivative cannabis-based products. So we're going to touch on pain physiology, diagnostic controversies, pharmacologic and non-pharmacologic treatments, and then a little bit about safety and efficacy of cannabis for chronic pain, and can we really use that to reduce opioid doses. So in terms of pain physiology, this is the current dogma. So the current dogma is that pain starts out here in the periphery. We have some sort of nociceptive driver that moves pain from the muscles, nerves, fat, peripheral tissue, if you will, up through the spinal cord into the brain through these facilitatory pain pathways. Once this nociception occurs in the brain, we put meaning on it, and then we call that pain. And then the descending inhibitory tract that takes it down from the brain back through the spinal cord, and essentially if you have a healthy central nervous system, sort of turns the pain off after the acute pain cycle is over. But in chronic pain, this is just a loop that goes on and on and on. So what we do in chronic pain is we use drugs on each side of facilitatory and inhibitory to try to mute the pain as much as we can. But the piece of this puzzle, this system that's a little bit out of date now is this role of the nociceptor. And the reason we think this is out of date is, why does this guy still have pain in a limb that is no longer there? In phantom limb pain, people will say they have stabbing, muscle cramping pain. It'll feel like the limb that's no longer there is still there and being held in an awkward position. So we're moving away from this idea that you need to treat the pain at the source where you feel the pain. So for years, if it was knee pain, we did injections. If it was jaw pain, if it was belly pain, we would do surgery to look at that specific area, because we were still working under the idea that pain starts where we feel the pain. Increasingly now we know that pain starts and lives in the brain and the spinal cord for many, many people. So this is the Oregon Pain Management Commission. If you haven't seen this 1 hour free continuing education about chronic pain. We made this with the idea that you could watch parts of this with your patient and have discussions. It's about talking about the pain experience. But for you guys, I think the important thing is we've got a brief section in there on this neuromatrix theory of pain, and that's what's controlled the gate control theory of pain that many of us learned when we were in school. And the neuromatrix idea, oversimplified, is that the pro-pain parts of the brain overtalk to other pro-pain, and then the anti-pain overtalk to the anti-pain. So it's sort of like left-wing and right-wing radio. It just keeps pushing things farther to the periphery. So even without significant nociceptive input from the periphery, the brain seems to perpetuate the pain cycle. So in terms of diagnostic criteria, let me talk a little bit about a contemporary approach to pain, then we'll talk about diagnostic criteria. So we sort of have three major buckets of pain: nociceptive, neuropathic, and central. And nociceptive, this is the kind we all love to treat because this responds to almost anything: NSAIDs, opioids, procedures, meaning surgeries, injections, acute pain, osteoarthritis, some cancer pains. But then there's neuropathic pain, which we're also familiar with, and if it's peripheral neuropathic pain, we really like that because we can order various electrophysiological tests and confirm that it's really there. We can see the lesion. If it's central neuropathic pain, like thalamic or multiple sclerosis pain, we can still see a lesion on some sort of imaging or other compound. But in terms of the drugs to treat it, it doesn't seem to respond as well to therapies as nociceptive pain. And then we have the pain where fibromyalgia lives. So this is centralized pain. Some people call it sensory hypersensitivity pain. There's a disturbance in the central pain processing such that light is brighter, noise is louder, pain is more painful, and even touch is painful. So that's why some people are calling it sensory hypersensitivity. And it's these things that all run together. So when you see somebody with fibromyalgia, it's very rare that they don't also have irritable bowel, temporomandibular dysfunction, some kind of chronic daily or migraine headaches, other sorts of pelvic and bladder sort of issues. So that's a classic. So I would ask you to sort of turn that on your head, and when you see a patient that has any other chronic painful condition, step back and think, do they also have fibromyalgia? It doesn't always go in that direction, but it's very rare to find someone with fibromyalgia without these other pain comorbidities. The important take-home message, though, is that although we start in these nice three little buckets of pain, over time, these things mix in most people such that we get these complex or mixed pain states, and this central nervous system dysfunction sort of bleeds over into central and nociceptive pain if you're genetically predisposed to having that happen. So just because you start in one pain state doesn't mean that's where you always stay. So in clinical practice, do you guys have some sort of body diagram that you can use with your people that have chronic pain? If not, get one. It's probably the most effective tool you have. Just ask them to color in the areas that hurt most days of the week. And if they color in 3 or 4 quadrants of pain, they have widespread pain. Once you know they have widespread pain, then you put on your hat of differential diagnosis, what else causes widespread pain. And if it's been going on for 6 months plus, or certainly 20 years plus, you can feel pretty confident that it's not going to be those other very ominous and malignant causes of widespread pain, or a terrible missed hyperparathyroidism or missed hypothyroidism for years. But in the beginning, there could be a bit of a workup as you're looking for other causes of widespread pain. But generally, by the time they get to me, they've had it for so long that there's really not another differential that makes sense for the unifying framework of what they have. So this person probably has some bladder or belly pain, probably has some tension headaches, probably has some TMD, neck and low back pain. So that's pretty classic for fibromyalgia. Some people just take a big X and put it through the whole body pain diagram. Importantly, what this person doesn't have is like a stocking and glove distribution just in the hands and feet. To have fibromyalgia, you need some axial involvement. So this person clearly has that. Something that we've researched at OHSU for about the last 5 years is, so we know that you need to have widespread pain to have fibromyalgia, but we're not all on the same page about what's the best way to know somebody has widespread pain. In clinical practice, it's really this body pain diagram. But if you're doing clinical research or you're doing research where people respond in mailed surveys or online, we can't come to a consensus about what's the best way to define chronic widespread pain. So we've looked at this quote from a patient many, many years ago that's, "I have a deep, persistent ache over most of my body." And that phrase by itself correlates highly with widespread pain, regardless of how we measure it, whether it's the number of body pain regions or 3 out of 4 on a widespread mannequin. So there's some interest in moving forward with this question. So I would just ask you to tuck this in the back of your head. If you have a deep, persistent ache over most of your body, that's likely going to be a widespread pain, which is likely going to be fibromyalgia, unless it's something that's new onset, right? New onset is a different animal. That's really put your diagnostic hat on, because then you've got some things to rule out. In this same study, we looked at about 26 different symptoms, and right now the going criteria is something called the 2016 fibromyalgia criteria, and that's based entirely on a questionnaire. And that replaced our 1990 criteria where we did those tender point evaluations and looked at widespread pain. And what we found is that the criteria for 2016 wasn't nearly as specific as what we're calling novel symptoms. So what really diagnosed fibromyalgia was this: I have a deep, persistent ache over most of my body. I have pain after exercise, or some people say I feel totally broken down after exertion. I'm sensitive to bright noise, loud noise, bright light, cold temperatures, and I'm just very tender to touch. You know, just don't hug me, don't get too close to me. And that really pulled our fibromyalgia patients apart from other patients in the chronic pain clinic. So is this the official diagnostic criteria? No. We're all debating what the new criteria should be. But these 2016 proposed criteria aren't turning out to be as specific as we would like them to be. Regardless of what you do, you need something to manage, mark how these patients are getting better or not getting better. So this is the Fibromyalgia Impact Questionnaire, the revised version. It's been around for 30 years. This version's been around about 10 years. 300 plus papers have used this. You can get it free at fiqr.info. Even if you don't score it, you could still just look at it with your eye and tell that people are getting better or not getting better. Because what happens, as you know, when you have a multi-symptomatic issue is when one symptom starts to get better, another one then becomes more, you're more aware of problems around another symptom. So to have something that you can look at visit after visit is really helpful. And this is so small, but let me just show you. These are 10 symptoms that are common in fibromyalgia, and the first one is pain. So if your patient has chronic pain, this is not going to be a good differentiator for fibromyalgia, right? So we need to look at some of these other symptoms. And the ones that are historically looked at are fatigue and sleep. But that's also not specific for fibromyalgia because lots of people have fatigue and poor sleep. So the ones that really popped up for fibromyalgia is this one around tenderness and actually being off balance, like physically off balance, and then sensitivity to bright light, cold temperatures, loud noise. So it's these bottom three on the questionnaire that are really turning out to be something that helps you diagnostically. So in summary, over time, most people's chronic pain becomes mixed or complex. We don't stay in that box we start in. The neurometrics theory of pain is now more accepted than the gate control theory of pain. Fibromyalgia, central nervous system dysregulation, is characterized with 30 years now of reproducible neurobiological findings. So we can't just sit back and say, this doesn't exist, there's nothing we can see, it's not reproducible. That's not accurate. It is accurate to say our treatments aren't as great as I'd like them to be, but it's not accurate to say we don't have lab findings, particularly neuroimaging, that would help us with this. So we really think of fibromyalgia as a complex to mixed chronic pain state, and we continue to have a diagnostic dilemma. So questions about this before we move on to pharmacologic management? Yeah.
Wouldn't a lot of that be attributable to depression? Depression
Yeah, so that is interesting because there are certainly people that have depression that don't have fibromyalgia, and everybody remembers the duloxetine Cymbalta commercials, depression hurts. That was the whole marketing theme behind that. So people with a chronic depression often have aches and pains. They don't often have that neurosensitivity that we see in fibromyalgia with the bright lights and cold temperatures and that sort of thing. But there's no question that they share some pathways between chronic pain and depression and even anxiety. Thank you. No, fMRI, that was probably the first neuroimaging finding that was found the blood flow to be increased to areas of the brain that are associated with pain and sort of this fight or flight sort of area in the amygdala. And then over time with PET and SPECT, we've seen that those areas of the brain that are responsible for pain processing are over-talking to each other. And there's a wonderful video series for your patients called Tame the Beast, and it's by an Australian physician, and he talks about how your brain and spinal cord are unnecessarily on alert when you have chronic pain or specifically fibromyalgia, and to understand that these messages that we're getting from the brain and spinal cord to retract and not move and protect ourselves are really not helping ourselves. Yes, I think you've been to the American College of Rheumatology. We debate this every couple of years. So depending on which diagnostic criteria you use, there's either an 8 to 10 to 1 female to male predisposition, or if you use those 2016 criteria, it's more like a 7 to 1 female to male predisposition. And chronic pain in the clinical world, if you are a person with chronic pain being seen at a pain clinic, you're much more likely to be a woman, whether you have fibromyalgia or some other thing. The animal researchers are working really hard. I was at a Ph.D. dissertation with Mary Heinricher earlier this week, or last week, sorry, about which parts of the on and off cells in the brain are not working based on sexual dimorphism. And so they're really trying to narrow in on what structures, supraspinal structures, are involved in perpetuating chronic pain in women. Right now, there's a little bit of what I would like to call blame the victim, which is, well, women have more chronic pain because, this is the dogma, there's more catastrophic thinking, more anxiety, more depression, and more, what do they call it, gender role confusion, or not confusion, that's not the right word, gender role, like you have less important things to do that you have to get done all the time. So, we were talking before this started about asthma, and when I was in school, asthma was only seen by allergists and immunologists because it was such a complex, poorly understood condition. We didn't know about mast cell stabilization and chronic inflammation and hyperreactivity of airways. But, that's everybody in chronic pain and primary care sees asthma now. And that's where we're moving with chronic pain, is that as we get a deeper understanding and eventually get better treatments, this is going to move out of rheumatology and pain clinics and anesthesia into the primary care space. And in fact, you probably already know this. There's lots of studies that show 4 in 10 of your primary care patients are there with chronic pain or a chronic pain complaint. So it's not that you're not seeing chronic pain patients. It's just that the science of what's wrong is ahead of the science of what seems to make it better. Okay? So let's talk a little about pharmacologic treatments. So if you've been in the world for fibromyalgia for the last decade, these are the same 3 FDA-indicated drugs we've had for a decade now. Pregabalin, which is an alpha-2 delta ligand, works on the facilitating side of the pain pathway. And then duloxetine and milnacipran, which are both SNRIs, and they work on mostly on the descending or the inhibitory side. So there's some idea that maybe you would choose one ascending and one descending and try to have them work together. The research is not terribly robust in that area. It looks like maybe a little better, but not a lot better. But the easy thing would be if your patient's already on an SSRI, which, Paxil, Prozac, those sort of drugs, have been found not to be as effective in chronic pain as SNRIs. So moving from an SSRI to an SNRI it would be an easy tweak. But unfortunately, really, the average patient will get about 30% better. So it's not like a statin drug for cholesterol where you're going to see a big jump in an easy to measure, biological marker. It's going to be how much better do you feel on a scale of 0 to 10. And at the end of the day, people that were in these trials on drug compared to placebo got about 3 points better. Now, of course, compared to placebo is not what we do in the real world. In the real world, it's on top of the 5 other drugs that you're already taking, right? So these are, safe drugs, but they're not, hugely beneficial as the next round of drugs, I'm sure will be. And if you monitor clinicaltrials.gov, you can see lots of drugs being tested for fibromyalgia that make it past, phase 2B studies and then have a negative third one and then don't go into large-scale phase 3 testing. Or sometimes they stay in phase 3 but don't get to FDA approval. Yes, you may. Yes. I spent about 10 years of my life on this agent. So sodium oxybate is the sodium salt of gamma hydroxybutyrate, and it's been known for about 20 years to have some effectiveness for non-restorative sleep, and there's definitely a bidirectional relationship between sleep and pain. So we looked at it in multiple studies, and we took it to the number needed to treat was quite larger than anything else that we had, better than anything else we had on the market. We took it to the FDA, and the day we were there, the date rape lobby showed up. Why do you think the date rape lobby would care about a drug for fibromyalgia? This is one of the date rapes. So this is a liquid. You can pour it in somebody's drink. If they're naive to drugs like this, you could pass out or be incapacitated. So the FDA said, tighten up your REMS program. We're worried about diversion. We were at the height of the OxyContin crisis when we were there. And long story short, it didn't get through. There's really good data for sodium oxybate and fibromyalgia. You can find it on the website of the company. We look at something called the Xyrem Success Program. You can't just write it and get a prescription filled at Fred Beyer. You have to order it online because they're concerned about it getting out of control and into too many people's hands. But if you happen to also have narcolepsy or hypersomnia, then we're having good luck with third-party payers reimbursing for it. If it's for fibromyalgia without hypersomnia or narcolepsy, it's a bigger lift to get that approved. I will say in the studies that some people loved the drug and they lost criteria for having fibromyalgia while they were in the studies. Other people hated it. They said it just felt like this wave of something was washing over them and they felt out of control and they didn't like it at all. So, it's not something that everybody that I've given this to thinks is the next greatest thing for fibromyalgia. But the patent life is too near the end now, and I don't think we're going to see a big push for this to get through. But there are several well-done clinical trials on sodium oxybate and fibromyalgia. Yes. Mm-hmm. Can you tell people how to find you? Because they're going to want to talk to you after. Okay. Well, talk to the gentleman in the orange vest about sodium oxybate, because this is a really good compound for the right patient. So these are sort of the strong evidence are for the alpha-2 delta ligands like pregabalin and gabapentin. When you look at the difference in gabapentin and pregabalin for fibromyalgia, it's really not that significant. It's just whether you want a TID or a BID dosing. The dual reuptake inhibitors, duloxetine and milnacipran, are approved for fibromyalgia. This one has a much bigger market share than milnacipran, which has a little more norepinephrine activity. The old drugs that we've used forever, like nighttime amitriptyline or cyclobenzaprine, are still grade 1 evidence for those, and we've talked about sodium oxybate. And then there's moderate evidence for tramadol with or without acetaminophen, so that's Ultram if you want to go by the brand name. The SSRIs is really just with if you add amitriptyline to fluoxetine, rather than use the newer, more specific SSRIs that just affect serotonin, don't seem to help fibromyalgia as much. Pramipexole is a drug we were very excited about a few years ago, so you'll still see some people on that, but it's very hard to ramp that up to a dose that's helpful for pain without being waylaid by nausea. And there's even some studies about gambling and risk behaviors once you get to higher doses with pramipexole drugs. Low-dose naltrexone, who's using low-dose naltrexone? All right, I've got a slide for you, because a lot of times when you come to a talk like this, you just want, can I just have one more thing I could try that I'm not currently using? So I'm going to show you a slide on low-dose naltrexone. Injectable growth hormone, spent a decade working with that. It's probably too far downstream. It's helpful, but we need to figure out why there's this problem with, because the problem's not in the pituitary, it's what's suprapituitary that's a problem in fibromyalgia. And then we'll talk just a few words about cannabis. And then in terms of no evidence or weak evidence, we're really moving away from the NSAIDs. Those studies have been negative for quite some time. Opioids, highly controversial. I'll talk to that in another slide. Corticosteroids, we did that study and those studies at OHSU, and either we don't have the right drug or the right mechanism, but those have not been positive. Benzodiazepines, I think, are highly effective for people that are having sleep issues, and again, the bidirectional sleep pain experience. However, those are going to be the next drugs with targets on their back, just like opioids are now. So we're going to see a big push to continue to pull benzodiazepines away from patients. So this is very small writing, but Ruth has the slides, and there's some copies here. This is literally the EPIC smart phrase that we use for low-dose naltrexone, so if you wanted to use that, you could. The idea is that it's a medication at high doses, like 100, 300 milligrams, treats opioid abuse or overdose by blocking opioid receptors, but when used at a very low dose, like 1 to 5 milligrams, it may actually help our own endogenous opioids be more active. You have to get it from a compounding pharmacy. These are some examples of that. This is exactly how you would ramp up the dose. And importantly, this is not a drug for people that are currently on chronic or high-dose opioids. This is for people that you've either gotten off of opioids or you're trying not to have on opioids in the first place. If you're who's on Twitter? Nobody's on Twitter. I'm the only one. All right. Well, Sean Mackey's lab at Stanford is the one that's doing a lot of the opioid tapering work and the low-dose naltrexone work and things like that. And they really have a strong Twitter presence. So I would encourage you to. It's just an easy way to keep up if you can follow the right labs. So this is people here in Oregon. I don't know if you guys saw this. We made the Boston Globe last summer. Oregon overshoots on opioids. A ban on Medicaid coverage would be cruel to patients. But I'm on the Health Evidence Review Commission and the Oregon Chronic Pain Management Commission, and we've been tasked with looking at opioids in our Oregon Health Plan patients, and do we really need to continue using opioids for chronic pain and for fibromyalgia. And the literature is not robust in saying, yes, we should use opioids, but it's also not robust in saying how you pull people off opioids. So the group has backed down significantly from this. We're going to have a rapid involuntary titration of all people from opioids, unless they have cancer or something like that, to something that's going to be more evidence-based. But the controversy is really we have limited RCTs for opioids, and then there's a lot of idea that if you take an opioid, you get opioid-induced hyperalgesia, meaning that when you take opioids, you actually have more pain than you had before you took them, if you take them long enough. But that's really has only been played out in animal models. We don't really have that evidence in humans, but it's become such a part of the popular culture that you'll see that quoted in papers a lot. But I would encourage you to go back and try to find the original source, and you'll see that it's animal data. So opioids are associated with cognitive dysfunction, constipation, dose escalation, and tolerance, but addiction and diversion are rare in fibromyalgia. In one study that we did, it was the #1 ranked medication by over 3,000 patients, so our patients are saying this is helpful. And I think importantly, as better therapies emerge, opioid use will decline. And also importantly, legacy patients. What do I mean by a legacy patient? Somebody that we've had on opioids for 10, 20, 30 years. I started in the 90s putting lots of people on chronic high-dose opioids, and we used long-acting so people wouldn't get that surge in activity that you do when you use lots of short-acting. But if these patients are taking off too quickly, they'll have mood issues and even suicidality. So I'm very concerned about involuntary taper, an abrupt taper in people that have been long-term opioids. So I think we really have to use the 2016 CDC guidelines with common sense, because those were written not about how to treat chronic pain. It was really about how to, part was how to treat chronic pain, but it's conflated with what to do about the overdose crisis that we have with opioids in the United States. This is just an example of one good evidence-based paper out of Sean Mackey's lab at Stanford. And this is Beth Darnell, who used to be with us at OHSU. And really, to do voluntary tapering, you needed 12 months and extensive support, meaning lots of other options, access to warm water therapy, massage, acupuncture, cognitive behavioral therapy. It's not just as simple as just starting to reduce the opioid prescription. Let's look a little bit at non-pharmacologic management. This is the take-home message. So there's a preponderance of evidence for exercise, hydrotherapy, and a variety of CBT, cognitive behavioral therapy techniques. Mounting evidence in acupuncture, diet, and mindfulness, and a very peaked interest in herbs and most specifically the cannabinoids. In terms of the major guidelines, the biggest take-home message is that fibromyalgia should be explicitly communicated to the affected individual so that you can have shared decision-making and this sort of activated patient. And this is different than 20 years ago when we used to not tell people they had that because we thought maybe having a label was not helpful. That would cause people to go down a less functional path, but that's really not borne by the literature anymore. Medication is common. You're going to just have multimodal therapy, some sort of aerobic exercise with some sort of psychological therapy and medications. That's the mainstay for fibromyalgia. So the idea that there's one drug or one surgery or one anything that's going to help fibromyalgia is just really not accurate. Some of the biggest effect sizes are in balneotherapy. So if you go to Europe and Turkey and lots of other places, this is a very common procedure or treatment for chronic pain and fibromyalgia. Here we don't use this so much, but exercising in warm water is really helpful. Natural resistance to muscle, it builds muscle as you move through the water. The buoyancy itself may reduce nociception by acting on both the thermoreceptors and the mechanoreceptors. So we may have a sort of a dual mechanism way of reducing pain. Decreases load on lower extremities. So if you have knee osteoarthritis and ankle and tendonitis and plantar fasciitis, this is an easier way to move around. So there's really strong evidence for this. The one caveat I would say is that many people with fibromyalgia, particularly younger people with fibromyalgia, have joint hypermobility. Some actually have Ehlers-Danlos, but they're somewhere on that continuum of having more hypermobility. So you can imagine as you drag your arm through the water, if your elbow's hypermobile, that lower part of your arm's going to go outside the natural joint line, and that eventually is going to create more pain in the joint. So if your patient is known to be hypermobile, they can easily get their thumb down here. They can easily put their hands on the floor. There's a 9-point criteria called a Beighton score that you can see if your patient's hypermobile. Then you need to give them special instructions as they're exercising in the water. So land-based aerobic activity really improves physical function and physical fitness. And that's really how you sell exercise in fibromyalgia, is that you will be more functional and you will be more fit. All of the balance, strength, flexibility, aerobic capacity, all that pops right back up in people with fibromyalgia that start to exercise. But what doesn't improve is sleep. So it's really not fair to expect people to say if you would just exercise, you wouldn't need sleep medication, your sleep would get better. That's really not borne out in over 76 trials now. What helps during the trial but isn't sustained if you stop the exercise is pain. So what is coming for pain and sleep? Really, it's these mind-body combination exercises to keep Qigong, yoga with mindfulness, Tai Chi done in land or water. And many of us are hypothesizing that it's because a big part of these therapies is sort of a cognitive script and a different way of sort of seeing yourself in the world that you can apply 24/7, not just for that hour that you're in an actual class. Cognitive behavioral therapies, this has been the mainstay for 2 decades. So at OHSU, we have something called a group cognitive behavioral therapy for insomnia. Do you guys have something like that here? So instead of one-on-one, it's in a group. If you don't, I'd really look at considering forming something like that. There's really good data that say group as opposed to individual is quite more effective in people with really recalcitrant chronic illnesses like the sleep issues within fibromyalgia. So for years, for cognitive behavioral therapy and acceptance and commitment therapies, that's what ACT stands for, we just really looked at this side, that people were distressed, they had traumatic histories, they were afraid of moving, and they catastrophized. But what we've seen really in the last decade is that anything that amps up these things help just as much as decreasing those things. So anything that improves social support, active coping, what can I do for myself to get better as opposed to what can you do to me to make me better. Acceptance of this is the new normal and this is my new screensaver and how do we move forward as opposed to trying to continually get like we were before we had a chronic illness. And then self-efficacy, watching other people like you be successful, having things that you attempt to do and you are able to master those and be successful is really important. How does the complementary evidence look? Qigong, Tai Chi, yoga with mindfulness, hydrotherapy, strong evidence there. Acupuncture, mixed evidence, but overall in the positive direction. These things are all small, consistently positive evidence, but very small trials. EMG biofeedback, weight reduction, manual therapy, certain types of massage, relaxation, biofeedback, mindfulness, hypnosis, guided imagery. And then this is the studies that are either negative or non-existent. So herbs, nutraceuticals, Reiki, homeopathy, magnetic fields, laser therapy, and phytotherapy. Where are we on time?
We've got 20 minutes.
20 minutes, all right. Questions about pharmacologic or non-pharmacologic management before we go into the highly controversial world of cannabis for a few slides. Yeah, so the question was about what's the dose and the frequency. So frequency, timing, type, intensity of exercise. And the general idea is those that started lower and ramped up more slowly had less dropout and less adverse events than those that sort of started with 3 times a week, an hour, go full tilt. So those very graduated protocols. And you can imagine those are very expensive to do, right? So the standard exercise therapy protocols that you can get funded for are 12 weeks. And what's that based on? That's based on the history of having exercise physiology students that are, 20 years old in their freshman 101 exercise phys class, and that's who is in the professor's studies. So we've tried to move that model into disease states, and it hasn't worked all that well, but that's still what funding is often based on, is a sort of more of a 12-week intervention. So we've learned that we have to start really slow and move up gradually. Okay. Other questions about pharmacologic, non-pharmacologic management? Yeah.
I've had a number of patients who are aging into the 65 and over category who have been on Lentio for a long time, and then I do severe criteria.
Yeah.
Will cover it. Any suggestions to push through? Because
Yep.
it should be pretty darn safe for them. They've been on it forever, or real concern?
Yeah, so our answer to that is push through unless that person is having fall risk and other things, they're actively falling. Having said that, we've done quite a bit of research about balance in fibromyalgia, and we find that the average 40-year-old patient with fibromyalgia has a fall risk that is equivalent to an 80-year-old. So when we put them on a balanced platform and move their feet in ways that doesn't make sense with what they're seeing in the environment, they fall into the harness more often. And it wasn't as simple, so I hypothesized that the problem was really just going to be sensory motor, but it turned out to look just like the model of aging, which is sensory motor, visual, and vestibular, just a little bit nibbled off of all of those problems. So yes, falls are more of a problem in fibromyalgia. And part of it is even speed of cognitive processing, because think about if you're on a TriMet bus and it stops really quickly, you're going to, without having to have conscious process, you're going to bend your knees to kind of stick your rear end out just to keep yourself on balance. And if it's a really big balance perturbation, you're going to step out and hold on to something. And all that has to do with your speed of processing, which if that slows down, because you have almost every chronic illness has some sort of cognitive piece, if in chemotherapy it's chemo fog, and fibromyalgia it's fibro fog, but it's all some slowed processing. So we think that's a piece of why we see more falls in these population. But it's always, is the patient better off with the drug and the symptoms that it's managing, or without the drug and the symptoms that it's managing? So we tend to, because that's one of the most benign things we do in fibromyalgia is amitriptyline or cyclobenzaprine. So we tend to move forward with that. Let's talk a little bit about cannabis and the cannabinoids for fibromyalgia and chronic pain. What's important for you to know is the lion's share of the studies around the cannabinoids and chronic pain are with the pharmacologic products. So dronabinol, which is synthetic delta-9 THC, and nabilone, which is a THC mimetic, and that's where most of the research is. Those are synthetics. These are the two plant-based products from GW. The Sativex, which they'll call naboxamils in studies, but it's just one drug. I'm not sure why it's called naboxamils, plural. It's a 1-to-1 THC to CBD mixture, and it's a liquid. You titrate it with a little dropper. And then cannabidiol, which is Epidiolex, which was just as a CBD only. It was approved in the United States in a Schedule 5 as of September 27th. So it's interesting that we have a Schedule 1 cannabis and a Schedule 5 CBD only Epidiolex. So this is approved for children with severe recalcitrant seizures, Dravet syndrome, things like that. They generally have seizures that are incompatible with life. So this is not approved for the treatment of chronic pain. But 87% of people in Oregon and 89% of people nationally with a medical card for marijuana aren't taking it for Dravet syndrome. They're taking it for chronic pain. Okay, so the whole cannabis industry is really largely about the unmet needs of chronic pain. So as we go through data, just keep in mind that it's not what you buy at the dispensary. It's mostly these products that have been in the studies. So this was the first big statement that came along. This is the National Academies of Science, Engineering, and Medicine looking at the health effects of cannabis and cannabinoids. You can download the whole document, 300 plus pages. You can go to YouTube and watch the authors be interviewed. But I'll just cut to the summary paragraph here. There is conclusive or substantial evidence that cannabis or cannabinoids are effective for the treatment of chronic pain in adults as antiemetics in the treatment of chemotherapy-induced nausea and vomiting, and for improving patient-reported MS spasticity symptoms, and then moderate evidence for improving short-term sleep outcomes in individuals with sleep disturbances associated with obstructive sleep apnea, fibromyalgia, chronic pain, and multiple sclerosis. So you'll see a number of systematic reviews and randomized there's more and more studies coming out on chronic pain and cannabis and cannabinoids, including now we're seeing quite a few on inhaled cannabis and vaporized cannabis. And it's so fun to read about these studies. We don't actually do these at OHSU, or I don't do these at OHSU, but when you're in these studies, there's the cannabis cigarette and then there's the placebo cigarette, and you literally have this sort of glass cone over you while you inhale the product because they want all the product to go in your system. The part of the reason I don't do this at OHSU is you have to get this not only funded, but then the DEA has to come out and make a site visit. You have to get your product from one particular field in Mississippi where NIDA grows the cannabis for all the NIH researchers. So it's quite a costly and time and burdensome experience to study it now. So we're really looking at Canada and Israel, two countries that have a longer standing way of studying this in a government sort of controlled manner. So lots of good studies coming out with Marianne, Mark Ware, and several others, Marianne Lynch. So we're looking to other countries. And I'm not saying we're not doing cannabis studies in the U.S. Some people really are fighting all those hurdles and getting it done, but it's a heavy lift to study actual Schedule I substance. This is a study this is Marianne Fitzcharles. She's a rheumatologist out of Canada. The effects of nabilone, so one of the THC mimic drugs, on sleep and fibromyalgia. This is a 2-week crossover RCT versus nabilone versus our gold standard amitriptyline at night, right? 29 completers, either one improved sleep, but nabilone improved sleep more than amitriptyline when measured by the Insomnia Severity Index, and marginally better on another sleep questionnaire. The important thing to look at with this trial is it's a 2-week crossover trial. And if you really dive down into the cannabis literature, you're going to find that the majority of RCTs are not parallel 12-week RCTs. They're crossover trials because we're sort of in a dose-finding phase still. So and what we want in fibromyalgia and in chronic pain in general is something we can use for decades, right? Because that's how long we're going to have chronic pain. But that's not sort of where the literature is now. And this is a 2018 Cochrane review that sort of says the same thing. Now, this was looking at chronic neuropathic pain rather than fibromyalgia because they had 16 studies with 1,750 participants. And they said, yeah, there's some improvement in symptom compared to placebo, but they've significantly excluded participants that have a history of substance abuse, other comorbidities, and these studies have small sample sizes, and as I mentioned, a lot of them are crossover design. So this study is about 2 years newer than the National Academies of Science statement. So I think we're starting to see now is that, hey, wait a minute, what about our patients in real life, like those that have a history of substance abuse or a family history of substance abuse, or they have multiple comorbidities? How are they going to do in these trials? Because to get in a lot of these trials, you had to have be willing to be randomized into a cannabis arm, and you had to have a positive previous good experience with cannabis, so to know that you could tolerate it. So that's an excellent first step, but it's not really generalizable to what we're all doing in practice. So a little bit about the adverse events is effect versus adverse effects. So when you're doing a clinical trial, you give people a big sheet of, have you had any of these side effects? And so if you say, yes, I used cannabis and I felt sort of giggly and my eyes got red and I felt a little euphoric, all that counts as adverse events, okay? But are they serious adverse events? No, there's really not serious adverse events. Even in the big study out of Canada that was specifically powered to look for adverse events. Cancer, not as a blanket statement. There are a few kinds of cancers that seem to be popping up that are disproportionate in people that use cannabis. The challenge is it's hard to find in sort of the natural studies rather than in an RCT, people that use cannabis that don't also use tobacco. So trying to find a cannabis-only user that's not a tobacco user is proving to be a bit of a challenge. But right now, particularly with lung cancer, the data is leaning on the side of not being a risk factor if you're cannabis-only. Heart disease and cerebral vascular accident, no shortage of published case studies, a pyramid of evidence sort of down here toward the bottom, case studies, that this could be problematic, particularly if you have unstable hypertension and unstable angina, and then you use a product that you inhale that immediately changes your blood pressure and your cardiovascular dynamics, that this might be a problem. But again, in the RCTs and the COMPASS trial, which is the big one to look at side effects, we didn't see that. Mental and cognitive health, there are some challenges here. Addiction, depression, psychosis, and schizophrenia, there's some evidence. And in terms of addiction, it was more in the sort of dependence as opposed to addiction world. And it seemed to be less habit forming than most other substances that we think about 9 to 12%. So nicotine would be more like 32%. certainly more than even cocaine and methamphetamine. So it is habit forming, but not a gateway drug that we were thinking about, except that it is a gateway to what other drug? Tobacco, right? So that's the concern, particularly in a young person. This is going to be a gateway drug to tobacco. Psychosis and schizophrenia, there is some, really looks like a dose-response relationship between number of years and exposure to cannabis and whether people have symptoms of psychosis or develop full-blown schizophrenia. Accidents, really motor vehicle accidents, when combined with other substances, yes, this is a problem. In the studies where they give people acute doses of cannabis and put them in a driving simulator, they do exactly what the jokes say. They go really slowly and they're a little paranoid and they're afraid to go very quickly. You put the same people in there with cannabis and alcohol together, and then they really overestimate their abilities, and that's where we see a lot of accidents. In terms of overdose, we don't have to worry about this the same way we do with opioids. The estimated lethal dose for 50% of the population is 1,500 pounds smoked in 15 minutes. So this is probably not going to be a problem of overdose for our patients. But there are definitely red flags for higher risk patients, pregnant women, people with abuse histories, people with family history of abuse, people with history of psychosis, schizophrenia, family history of the same thing. Then that's really where we have some red flags. If you want to hear more about this, there's a 4-hour continuing education that we do at OHSU. It's next on October 19th, both live and virtual. We do pharmacology, pain, multiple sclerosis, pregnancy, pediatric seizures, risk, events, economics, local issues in Oregon and Southwest Washington. So feel free to join us for that if you want more about cannabis. What about the role of using cannabis to reduce opioids? How am I doing on time? 8 or 9 minutes. All right. So this is a study out of Ann Arbor, Michigan, where Dan Claw and his colleagues went into dispensaries and asked people who were basically in line, saying that they had a card for chronic pain. They found in 244 people that using cannabis was associated with a 64% reduction in opioid use and a 45% improvement in quality of life. So in this very selected, self-selected sample, there was some signal or some evidence that maybe some people are using this to reduce their opioid dose. This was followed up by a study out of Israel, an open label, so a more prospective study of 274 people on their medical cannabis program. It looked like it did for chronic pain over a 6-month period, and patients did report improved pain severity and interference, but more striking, and what the authors weren't expecting, is that 44% of those on opioids had self-discontinued their opioid treatments. And then there's a lot of data I'm not going to show you today about how much savings, and you've seen this on billboards, $1 billion in savings if every state in the United States had medical cannabis, that money we would save. In part, that's because you have to buy this out of your pocket. When you have a card, you just don't pay the tax. It's not that the drug is free. You still have to buy the drug. So this is the study we're all waiting for, a $2.4 million NIDA-founded grant to look at 250 people who are HIV positive with sensory neuropathy, and really an observational prospective cohort study over 5 years to look at what's really sort of that recipe for titrating people off opioids by using cannabis. I've started to see the baseline papers come out of this, so it's a lot of demographics, who's in the studies, but no recipe yet about how the patients are doing to coming off opioids with cannabis. So this is my last slide. So fibromyalgia summary. Chronic pain may be initially nociceptive, neuropathic, or the sensory hypersensitivity, but over time, central nervous system dysregulation occurs in many people, so that many people move toward that red box of fibromyalgia and sensory hypersensitivity. And practice really involves these 8 important strategies. So provide the patient with an early and accurate diagnosis. You don't have to wait years and do lots of unusual tests. You can pretty much say on visit 1, if they've had it for several years, maybe we're going to check your SED rate and your thyroid and a chem profile and just a few other very common things. But usually somebody that's had widespread pain for years is going to have fibromyalgia. normalize that multimodal therapy is normal. Even though you can get on the internet, and patients will, and I don't blame them, they'll find lots of, if you just take this product, then you're not going to need to be on all those other things. If you just have this one surgery, you're not going to have these problems anymore. And one of the most popular surgeries that fortunately is sort of waned in its popularity now, but it was to make an incision in the base of the skull and allow the brainstem to sort of, it's a Chiari-1 malformation surgery, just to give it a little more room and have more pressure and release. But fortunately, we're not seeing that as much anymore. But that's the kind of things that take hold in this community because the problem's so symptomatic. So prescription medications, there's 3 FDA-indicated drugs, and as we've heard from others here in the audience, there's several others that may be helpful. Exercise is one of the main pillars. People have to move, and it's just that start low, go slow. How do you get them into something where they're moving several times a day? You would need to enlist practitioners of cognitive behavioral therapy and acceptance-based therapy, even if patients aren't depressed. We used to hold these therapies back and only use them when people had significant depression or significant catastrophic thinking or early adverse life events. But now we see, remember, from that positive side of the diathesis, that really anything that helps improve self-efficacy, mastery, acceptance of a new diagnosis or a new way of being essentially is helpful. We need to use a rational, individualized approach to several other therapies when they're beneficial compared to placebo, and that's essentially spacing things out over years because that's how many different things we have to try. Use the Fibromyalgia Impact Questionnaire or some sort of questionnaire that focuses on function and lots of symptoms and not just that pain as the 5th vital sign. That's a very difficult question for patients to answer. What's your pain level today? You mean my back pain or my normal baseline pain or the reason that I'm here today, which is the pain in my knee? It's just a hard question for people to answer that have chronic pain and particularly fibromyalgia. And it looks like cannabis is safer than opioids in selected populations and provides some symptom relief. So I'll stop there and see if anyone has any questions. In the back, yeah.
What about CBD oil? A lot of people talk about that decreasing inflammation for a variety of
Yeah.
reasons and not having THC.
Yeah, and that's based on animal studies and the Rick Simpson oil and those sort of things. Very interesting, very promising. If you look at the sort of pyramid of evidence, we don't have any of that. We don't have a CBD-only study in chronic pain yet, so it's hard to know. A lot of the products you can get at the dispensaries. I think the take-home message from the dispensaries is the recreational products are not medical. So any of the concentrates and dabs and shatters and all that sort of stuff is not where we want to steer our patients. If they want to try something, and they're not in one of those high-risk groups, something that's a more balanced ratio or a CBD only might be a good place to start. Other questions? Oh, yeah.
Is there any overlap between fibromyalgia and PTSD?
The people with PTSD are more likely to have fibromyalgia than people without PTSD, and we think maybe it goes back to the ACEs study that we've all talked about for years now about early adverse life events and how some of those children develop various biological things, even asthma and allergies and autoimmune disease, and others do not. So we don't have a clear cause and effect, but there's definitely a correlation between lots of different mental health issues and chronic pain and fibromyalgia. Did you have?
Yeah, I was curious. Savella is $400 to $500. How do you get your patients covered?
It's very difficult, even though it's FDA indicated, Savella is very difficult to get covered. If you look at the clinical trials, it's got a very small market share, but if you look at the clinical trials, it had a little more norepinephrine, a little more noradrenergic activity, so your patients that are very, fatigued all the time, maybe that's an example to try that one over a different SNRI like a duloxetine, Cymbalta, but it's a lot of prior auths to get that one covered. And the studies, there's a venlafaxine. Am I saying that right? Venlafaxine, thank you. I need more coffee. That was positive in fibromyalgia, but that was off patent life before the drug had a chance to be marketed, so you just don't hear about that.
So
I'll just step in and say it's 9 o'clock, and Dr. Jones may or may not be available
I
for
can.
a few minutes for questions if you want to come up afterwards. So thank you.
Thank you.